Hi, my name is Eric Wagner, and I'm at Emory University. And thank you for the opportunity to talk about wrist fractures, utilizing value through evidence-based medicine. Did you reach out to me if you had any questions about this? So my disclosures can be found at the Academy's website. So value and patient per outcome measure collection, I want to credit my mentor and commandant, Dr. J.P. Warner. He's somebody who has really pioneered this realm in shoulder surgery and somebody I've learned a lot about, both how to evaluate value and apply evidence to that value equation. So Michael Porter talked to us about this equation of outcome versus costs, or value equals outcomes over costs. And there's many considerations, whether it's from the hospital standing, where you're looking at income, outcomes, costs. We demonstrated that higher volume leads to lower rates of complications and ultimate lower overall costs, both with regard to providers and hospitals. Surgeon value. So this maybe deals with outcomes, income, time expenditure. E.A. Cobman had this great cartoon that talks about, in his mind, the value to the surgeon and value to the patient. And that kind of brings us to value patient and really centers around outcomes. Maybe also return to play or work, the overall cost to them and to their insurance. Um, Kind of interesting. Michael Porter has demonstrated this value-driven outcomes programs that are able to drive both outcomes and clinical costs with a focus on both efficiency, identifying high variability, kind of reducing costs, improving outcomes. So it's these value-based outcomes tools that can improve quality and costs. So I'm going to go through some evidence in wrist fractures and how you can sort of parse out some of the value from the evidence-based literature. So in the distal wrist fracture, when you're looking at the value versus outcome over cost equation, there has been a huge amount of studies in recent years, as it's a very hot topic, especially in the last 2 decades. It's also a very common fracture, as 18% of fracture over the age of 65 are just raised fractures and a very high overall cost associated with it. So I'm going to go through sort of an evidence-based approach, looking at a lot of these different options. So wrist arthroscopy is one that personally near and dear to my heart. Is something I do a fair amount of and very much enjoy. So when you look at distal raised fractures, 68% had PFCC or SL pathologies. Ulnar positive variance was associated with increased risk of SL tears. And if you had greater than 2 millimeters of step off, you had a risk of arthritis. And this has been shown over and over again. If you have step off, you do get arthritis after just raised fractures. This is a really nice study I watched you showing 13 of 16 patients had arthritis at 15 years post-operatively, likely due to some aspect of step off. Interesting enough, SL is not something that I think is worth with regards to with arthroscopy. So evaluating step off is important, but evaluating whether there's an SL tear probably is not as important, as there's no difference in this respect. And so therefore, the value of wrist arthroscopy is a bit unknown. I do think maybe there's some value long term. We haven't proven that. Definitely increases operative time, but it kind of depends on how much that actually is. One thing I would say that there's value with is with regard to making sure the radial styloid is reduced, ulnar fossa reduction. In a young patient with an interarticular fracture, there is value in preventing potentially future arthritis by helping eliminate some of these step-offs. So here's another one, formal physical therapy. Well, some say that it improves outcomes. Some say that it doesn't actually improve outcomes. And ultimately, comparison studies like this one, Kevin Chung showed that formal and home therapy actually had very similar overall patient per outcome measures. So at this point, there seems to be limited evidence to guide who benefits from formal therapy and who doesn't. There are some that do, but definitely there are some that don't. And so it's sort of questionable the value of formal physical therapy for these distal fractures. And ultimately, I think it's then important to use it as a shared decision-making process, as this really nice book talks about, thinking fast and slow, kind of slowing down and using this shared decision-making process with the idea of physical therapy for your patients. Surgical indications is another interesting one. So those less than 65 years of age, if there are certain things like incoronal malalignment, and this is associated with the increased risk of distal radial ulnar joint instability. Greater than 3 millimeters of shortening or dorsal tilt, or as we talked about, that interarticular displacement. All these in the younger patients are predictors of who potentially needs surgery, and there is some value associated with them. That being said, with these studies have shown improved outcomes, I do think it can potentially offset and create some moderate value compared to the societal and surgical costs. The elderly is a little bit more controversial. So some suggest that volar tilt and ulnar variants improve outcomes or directly impact outcomes. Some have shown that non-operative treatment has a higher risk of median neuropathy. Operative treatment has a higher risk of surgical site problems, CFBS, tendon injuries. So it's a bit controversial. Radiographs definitely are better with operative management than non-operative management, but this has not always shown to be translated in the clinical arena. And ultimately, in multiple comparative studies, prospective comparative studies, early function and grip strength favors surgery. Now, overall clinical outcomes is potentially similar. So it all depends on kind of, once again, what your patients are wanting. There are some studies that suggest that surgery is cost effective as it improves overall qualities compared to non-operative treatment. And when you look at the overall survival after a distal radius fracture, this is an impact. There is a big impact on the survival in the elderly. Not quite as profound as in the hip fractures, but it is relevant. And thus, I think maintaining a certain functional status is not insignificant. So you could argue that from a functional standpoint, so status standpoint, despite the potentially higher costs with operative treatment, the functional status potentially does increase the overall outcomes, and you could argue potentially prolongs people's lives. Once again, that goes back to that idea of shared decision making between the patient and surgeon, and a lot of other factors that contribute to it. So osteoporosis evaluation is another important one. So distal radius fracture occurs years before hip fractures in these osteoporotic patients. And that early initiation of bisphosphonates actually did not have a big impact on healing rates. We give this to all of our patients. This idea of bone health with regard to calcium, vitamin D recommendations, I do think it's important in these patients that have distal radius fracture, especially the older patients. And I do think that there's high value in osteoporosis treatment in these patients, as it potentially helps to prevent future costs. Vitamin C is another interesting one. So there has been, there was an initial study that showed that there is an impact of vitamin C on CRPS. Multiple other trials with a large number of patients actually have shown that there's no benefit of vitamin C. And thus, although it's very low cost, because it's very low cost, even if it's equivalent outcomes in relatively high series, I do think there is some moderate value with vitamin C, particularly in those high-risk patients. Non-operative treatment is another interesting one. So how do you actually treat these non-operatively? So casts help with pain, but not necessarily fracture alignment. There is an 89% interval displacement in these non-operative patients, particularly in those elderly patients. And short arm casts and long arm casts basically are equivalent, with long arm casts having potentially a little bit better volar tilt, while short arm casts has higher patient satisfaction. And so there is some value in treating a patient with a short arm cast, increases patient satisfaction at a low cost. And I would argue this is a relatively high value proposition. And then finally, serial radiographs. So if you look at a patient that has multiple radiographs over a period of time, if you have no radiographs after 2 weeks, there's no impact on overall outcomes. And thus you could sort of argue that serial radiographs actually have low values. They have increased overall costs without the benefit of improved outcomes. And then finally, with distal radius fractures, the type of fixation, so distraction plating versus fragment specific versus volar plating. Basically, there is very good evidence for each one of these. Fragment specific and volar plating is equivalent. K-wire to volar plating and even X-fix to volar plating. Really, not a lot of difference between a lot of these different techniques. One maybe exception is the volar plate versus a dorsal plate. You have less complications associated with the volar plate. especially with regards to tendon irritation. And thus, in general, there's moderate value with any fixation technique, and there's really not a good evidence-based algorithm to truly tell you which is the superior fixation technique. And then finally, opioid-free multimodal protocols. This is something that we have really helped to try and pioneer a fair amount at Emory. There's multiple prospective evaluations in hand surgery on opioid-free protocols, looking at ways to curtail this opioid epidemic. Not going to go into a lot of our studies, but I do think that there's high value in finding alternative pain protocols besides opioids in a multimodal fashion to help improve patients' recovery and control their pain. So another idea, this value I want to talk about, or value in evidence-based value in risk fractures, is scaphoid fractures. So when we're talking about scaphoid fractures, we're talking about both acute and non-unions, but we're starting out with acute, and you can see in general, there's a huge boom in the last decade of studies on scaphoid fractures, as this is a very common fracture overall, the most common carpal fracture, and something that has a big impact on patients' risks. So dealing with the non-displaced fracture first, those that have an SL angle greater than 60, 1 millimeter of displacement, or radial leading angle is 15 millimeters, all are different options to sort of define this idea of displacement. Non-displaced, there is some value in this. So in truly defining what actually is displacement. So scaphoid back less than 2 millimeters. Interesting enough, the CT and X-ray findings were not correlated with stability and arthroscopy. And thus, that's important because operative versus non-operative treatment of non-displaced fractures is relatively equivalent, actually with potentially even higher complications with surgical treatment. That being said, surgical treatment can also get you back to work earlier, get you back to functional status earlier. So it is a bit controversial on the treatment of these non-displaced fractures, not only the definition, but also the treatment. This is a kind of an interesting set of studies looking at the cost effectiveness, actually suggesting surgery is more cost effective, especially from a societal standpoint compared to non-operative treatment. And this thus suggests that for non-displaced fractures, there is some evidence suggesting maybe surgery is the cost-effective approach given the earlier return to work despite the equivalent outcomes. Once again, this is a sort of shared decision-making process between you and your patients. So non-operative treatment methods is also kind of interesting. So when you cast, the most important thing is actually control wrist extension and ulnar deviation, not necessarily supination, pronation, not necessarily your thumb motion. Once again, it's wrist extension and ulnar deviation. Thus, thumb spicas, long arm, short arm casts are all equivalent, as in multiple comparative studies for these non-operatively treated fractures. Furthermore, 12 to 14 weeks is the gold standard for immobilization. However, if you get a CT scan earlier, potentially 6 weeks like we do, and you have greater than 50% healing, you can potentially get them out of the cast a little bit earlier. So this kind of demonstrates that short arm cast does have some value, and particularly if you get the CT scan at 6 weeks, you can potentially improve that cost benefit ratio and this outcome versus cost equation to actually demonstrate some moderate value. So these displaced fractures, now this is not controversial. You do need to have surgery on these. The placement, the technical consideration for surgery is a bit controversial. So central screw potentially has better stiffness. Otherwise, you can also have a perpendicular fracture. Some would argue volar versus dorsal. The volar has initially was thought to have a high rate of SCT arthritis. It's been kind of misproven and shown that it's not actually true. And then general volar versus dorsal is relatively equivalent, with the exception of maybe the proximal poles, where dorsal is superior for these fractures. And so in general, the surgical considerations, the approach, the type of screw, where you put the screw, it's all kind of questionable on this value proposition curve. Imaging considerations, another important one. So radiographs only have a 27% negative predictive value. And thus, if you combine examination, so cephalothoracic tenderness, scaphoid tubercle tenderness palpation, and scaphoid compression tests, you actually have a pretty high sensitivity and specificity. So physical exam is very important. That being said, many studies have demonstrated the cost effectiveness of early MRIs in diagnosing these and allowing patients to sort of proceed along the treatment algorithm. CT scans really, at least in my mind, are more important for fracture characteristics and help with surgical planning in certain circumstances. But that being said, an early MRI does lead to faster decision making, and you could argue is a cost effective and thus having relatively high value. So other common fractures, I'm just going to kind of go through this quickly to show some of the evidence behind these. So overall, if you have a non-displaced body or tuberosity fracture, you can treat in a short arm cast for 4 to 6 weeks. If you have a displaced body or tuberosity fracture, you can either do a CRPP or ORIF. And if you have an unstable CMC fracture, you probably should do either a CRPP or ORIF. So for the dorsal cortical fractures from the tight cruciatus, in general, 2 to 4 weeks of a short arm cast or splint, even a removable splint probably is equivalent. The transverse body fractures is usually a perilunate equivalent. And thus, these and the volar avulsion, which is an LT equivalent, often do require some sort of surgery to deal with that ligamentous injury. Trapezium, you have a displaced volar ridge. These often can be excised. From the lunate standpoint, either displaced volar or dorsal lip fracture, you often are considered either a SL or LT avulsion fracture and often need surgery to fix these. Non-displaced waist fractures of the capitate, you can treat in a short arm cast. Obviously, if they're displaced, you want to treat them surgically. Scaphocapitate syndrome is a part of the perilunate injury, and these are often these displaced transverse waist fractures. Okay, handmate is that thing you see often in golfers or other rapid sports. Can be associated with Guillen's or carpal tunnel syndrome, and I do think it's worth excising this if you have either of those or if it's displaced. Transverse hamate fractures, you want to evaluate for the perilunate injury, and then pisiform fractures, if they're displaced or symptomatic, you can excise them pretty easily. And then finally, trapezoid, it's really dealing with the CMC. If there's unstable CMC, you want to stabilize the CMC. And thus, there's questionable on the value equation with these. Some have shown good outcomes, and some have a sort of positive evidence surrounding them. So some final considerations with these sort of value equation that we talked about. Once again, value equals outcomes over costs. And if you always reference back to this, it helps to understand, at least in my mind, a nice way to think about approaching many of these carpal fractures and evaluating both those treatment decisions like MRIs early on in scaphoids, evaluating other diagnostic modalities, as well as how to evaluate operative versus non-operative treatment for some of the more controversial ones. Please reach out to me if you have any questions. This is my email address and my cell phone. Yeah, thank you for your time. This is always a fun topic to talk about, with incorporating evidence and value and helping to shed some light, at least on our decision-making process in a lot of this. All right, thank you.